Let's talk about upper GI hemorrhage now. This is a topic which invariably yields one short note and an MCQ in the entrance exams. Now, upper GI hemorrhage, the classical definition of upper GI hemorrhage is bleeding above the ligament of Treats. This is bleeding above ligament of Treats. That is upper GI hemorrhage by definition, right? Now, upper GI hemorrhage, before we talk about the causes of upper GI hemorrhage, you need to know that the diagnostic tool for upper GI hemorrhage is going to be upper GI endoscopy, right? So patient can come with bleeding, but the diagnostic and the therapeutic tool regarding what is the cause and how do we manage it is going to be upper GI endoscopy. So why I want to show you a video of upper GI endoscopy is because this time in the INI CET exam also they had asked about the upper GI endoscope and colonoscope difference. So let me just quickly first show you what is the difference between an upper GI scope and a colonoscope. So the main difference is just the length. The length between the two is different, and that is how you identify. Unfortunately, in this year's INI CET exam, the images were so small that students were unable to differentiate. But because they've asked this topic once, they can ask it in the future. So you need to know this, that this is a colonoscope, which is the longer one. You know that the length of the colonoscope can range between 110 to 140 centimeters. Whereas the upper GI scope is shorter. The upper GI scope is shorter. It ranges between 80 to 100 centimeters. Of course, you don't want to put a colonoscope through the mouth. So that is, the length is the main differentiator, how you can differentiate between the two. Now, let me just show you a short clip of how upper GI endoscopy takes place so that you just have an orientation of the structures, and then we'll talk about the causes and the management of upper GI hemorrhage. So this is the video of an essentially normal upper GI endoscopy which was shared by my uncle who's a gastroenterologist at Hopkins, and you can see the postcricoid region, and you need to know that the measurement is always done from the upper incisor, okay? Now this is the GE junction. You're going through the GE junction and you can see a change in the mucosa, right? Once you enter from the esophageal to the GI mucosa, you can see the gastric folds. This is the pylorus body antrum, and now you enter the pyloric sphincter and you are going to enter the duodenum. Again, you see a change in the mucosa. The gastric folds are now changing into complete circular folds in the duodenum. So you go up till the duodenum, and that is the upper GI endoscopy. Then you start withdrawing and you come out, and even while withdrawing you look at the various structures. Now, if you want to look at the fundus of the stomach, we have to rotate the scope, right? We have to rotate the scope to look at the fundus. So that is known as a U-shaped maneuver or a J-shaped maneuver. That is to see any growth or any ulcer at the fundus of the stomach. Right, so that was regarding upper GI endoscopy, which would be the diagnostic and therapeutic tool when we talk about upper GI hemorrhage. So let's talk about the causes of upper GI hemorrhage. Now, upper GI hemorrhage, I've already told you the definition. Upper GI hemorrhage, you can either have non-variceal causes or you can have variceal causes. So you can have non-variceal or you can have variceal upper GI hemorrhage. Now, it is a common misconception that students think that upper GI hemorrhage is more commonly due to varices, esophageal varices, but that is not the case. Non-variceal hemorrhage is much more common than variceal upper GI hemorrhage. Non-variceal hemorrhage forms almost 70% of cases, whereas only 30% cases are due to esophageal varices. So first, let's talk about the non-variceal causes. The non-variceal causes, the first one which you need to know, the most common cause of upper GI hemorrhage. This I've already told you when I was talking about ulcers in the stomach module. The most common cause of upper GI hemorrhage are peptic ulcers. These are peptic ulcers, and you need to know that peptic ulcers, duodenal ulcers bleed more commonly than gastric ulcers. This also we have discussed. Duodenal more common than gastric ulcers. This we've discussed. And while we were discussing this, we also discussed that it is the posterior duodenal ulcers which bleed more commonly. It is the posterior duodenal ulcers which bleed more commonly. And the vessel implicated also we've discussed is the GDA, gastroduodenal artery. This has also been asked many times in the exam, is the gastroduodenal artery. And if you have a bleeding peptic ulcer, I told you the management is going to be at least 2 attempts of at least 2 attempts of endoscopic management, at least 2 attempts of endoscopic management. Only if they fail, then we will do surgery and we will underrun the vessel, or we will underrun the vessel and stop the bleeder. So that is regarding peptic ulcers. That is the first cause which we need to know. The second most common cause is gastritis. Now, gastritis can be of multiple types. Let's talk about the various types of gastritis. So, gastritis can be type A and type B gastritis. The first types, you can have type A and type B gastritis. Now, type A for autoimmune. That's how you remember it. A is autoimmune gastritis. A is autoimmune gastritis, and in this condition, there are autoantibodies against the parietal cells. There can be autoantibodies against the parietal cells and the intrinsic factor. Right. So these patients, the clinical features of these patients, they will have hypochlorhydria because of hypochlorhydria is going to be there because of antibodies against the parietal cells. They will have pernicious anemia. They can have pernicious anemia, these patients. 20% of these patients can have vitiligo or Addison's disease associated with them. 20% can have vitiligo or Addison's disease associated with them, and this increases the risk of cancer. This increases the risk of gastric cancer. And you need to know, autoimmune gastritis, antrum is spared here, right? A antrum is spared in these patients, so it is mostly affecting it mainly affects the body. The antrum is spared in these patients. So this is autoimmune gastritis. B is bacterial, B for bacterial, and you know the bacteria which causes havoc in the stomach is H. pylori. So this is H. pylori induced gastritis. And unlike type A gastritis, here antrum is commonly involved. Antrum is most commonly involved. In elderly patients, there is a variant of type B gastritis where it can give rise to pan-gastritis, where the entire stomach is involved. That can be pan-gastritis, and this also increases the risk of cancer. So both the types are increasing the risk of cancer. You can see here pan-gastritis is seen in elderly patients. Pan-gastritis is seen in elderly patients with type B gastritis. Antral gastritis is again H. pylori induced, and gastritis in the body of stomach is type A or autoimmune gastritis. Now, another type of gastritis which you can get is stress gastritis. This also we have discussed when I was telling you about head injury in the head trauma module. I've told you about stress gastritis. There are two statements which I want you to know before I tell you about stress gastritis. The first statement is that the most sensitive GI mucosa to hypovolemic insult. Most sensitive GI mucosa to hypovolemic insult. What does this statement mean? That whenever there is hypovolemia, which is the GIT mucosa which will first react to it? And the answer here is gastric mucosa. Answer is gastric mucosa, and this is one reason why you get stress gastritis, where you get these stress ulcers in the stomach, okay? Because the stomach mucosa is the most sensitive. But the other question is, what is the most common site for ischemic colitis? So ischemic colitis most commonly is seen in the splenic flexure. These are two separate questions. Please don't get confused between the two. A lot of students last year and last to last year messaged me regarding these two statements. They both are very different and you need to understand them, okay? This splenic flexure we've discussed in the colon chapter. Why is this affected? Because splenic flexure is a watershed area. The blood supply there is dicey, and that is the most common site for ischemic colitis. Now these stress gastritis, you know, these stress ulcers, you know, can be either Cushing ulcers or curling ulcers. Cushing or curling ulcers. And we've discussed this. Cushing ulcers are seen in head injury, whereas curling ulcers are seen in patients with burns. Curling ulcers are seen in patients with burns. And Cushing ulcers, according to the latest Bailey, the most common site is the acid producing area of stomach. Whereas curling ulcers, the most common site, this was described by curling and it was typically described in the first part of duodenum. So these are the stress ulcers or stress gastritis which you should know about. Now another type of gastritis is of course due to NSAID consumption, painkillers. Those who take a lot of painkillers, you can have NSAID induced gastritis. And in HIV patients there can be HIV gastritis, and this is due to cryptosporidiosis. Which can give rise to gastritis in HIV/AIDS patients. So these are the various gastritis you should know about. The next cause of upper GI hemorrhage is a Mallory-Weiss tear. Now Mallory-Weiss tear is a longitudinal tear. This is a longitudinal tear which starts at the GE junction and proceeds below towards the cardia. Right? So it's a longitudinal tear, and mind you, one point of difference between a Mallory-Weiss tear and Boerhaave syndrome. You remember Boerhaave was spontaneous esophageal perforation. That means all the layers were getting torn and there was a perforation there. But in Mallory-Weiss tear, there is just a mucosal, most commonly is mucosal, but sometimes the submucosa only gets split. But the rest of the layers are intact, so it's not a perforation. It's a longitudinal tear and it is usually a mucosal. Most commonly it is mucosal. Sometimes submucosa is also involved. And it proceeds towards the cardia. Now the clinical features, this is again seen in alcoholic patients just like Boerhaave syndrome, and this is also seen after forceful vomiting just like Boerhaave syndrome. But this is going to come with upper GI hemorrhage, and you know Boerhaave syndrome patients, they come with chest pain, retching, subcutaneous emphysema. So the presentation is different. These patients come with upper GI hemorrhage, and the diagnosis is made by upper GI endoscopy. I've already shown you a normal upper GI endoscopy, and the vessel implicated here. Right, the vessel implicated, this was asked in one of the AIIMS exam 2 years back. The vessel implicated is the left gastric artery. So please remember this. It is the left gastric artery which is implicated here. Left gastric artery, if you remember, was also implicated in the bleeding of a type 4 gastric ulcer. Type 4 gastric ulcer was also left gastric artery. Now one point which I want to tell you here, students get confused. If you are asked in the exam, which is the most common vessel implicated in peptic ulcer bleeding? So you know that duodenal ulcers are more common than gastric ulcers. So which will be the most common vessel implicated? Gastroduodenal artery, not the left gastric artery. If you are asked the vessel implicated in bleeding gastric ulcer or a Mallory-Weiss tear, then the answer is going to be left gastric artery. Now the management of these patients, it is usually a self-limiting bleed. So it stops on its own. If it persists, then we can carry out angioembolization. Then we can embolize the bleeding vessel, angioembolization can be done. Or we can do cauterization, or cautery can be done of the bleeding vessel. So this was regarding Mallory-Weiss tear, asked quite frequently in the exam. The next topic which we need to talk about is GAVE. GAVE stands for gastric antral vascular ectasias. This is gastric antral vascular ectasia. This is GAVE. And in GAVE what happens, that there are dilated submucosal venules which are responsible for the bleeding, dilated submucosal venules. So how do we remember this? GAVE has a V in it, so these are venules, dilated submucosal venules which can bleed, and as the name suggests, this is only in the region of the antrum. This is more common in females as compared to males, and it can be associated with collagen vascular disorders. It can be associated with collagen vascular disorders like SLE. And the clinical features, patient is going to come with upper GI hemorrhage. The diagnosis will be by endoscopy, and when we do an endoscopy, we get a classical watermelon stomach, right? We get a classical watermelon stomach. This has been asked many times in the exam. Watermelon stomach is seen in which condition? It is seen in GAVE because the appearance resembles the outer covering of a watermelon, right? And the management of GAVE, when you have a patient with GAVE, the management of GAVE is APC. APC is argon photocoagulation. In severe cases, if APC is also not working, in severe cases, we carry out antrectomy. We have to carry out antrectomy. That means we resect the antrum. Now, another point which I want you to remember here, that in watermelon stomach or GAVE, body is spared. Body of the stomach is spared, and when we do an endoscopy, this is the point which helps us in differentiating it from portal gastropathy. So the image on the right hand side is of a patient with portal gastropathy. So portal gastropathy is seen in patients with portal hypertension. This is seen in patients with portal hypertension, and in this condition the body is also involved. Body is also involved here, and in these patients, what are we going to get? The appearance is of a snake skin appearance. This is snake skin appearance, or some people like to call it a strawberry stomach. A strawberry stomach, and the management would be the management of portal hypertension. So please remember, GAVE is venules, you get watermelon stomach. Portal gastropathy, the body is also involved, and you get snake skin appearance or strawberry stomach, right? Now, in this condition, what was happening? In this condition, the venules were getting involved. There is another condition known as Dieulafoy's lesions. Now, Dieulafoy's lesions are dilated. These are dilated submucosal arterioles which can bleed. So these are dilated submucosal arterioles which can bleed, unlike GAVE where venules were bleeding. Okay. Now this condition is seen in elderly patients. This condition is seen in elderly patients around the 6th or the 7th decade of life. 6th or 7th decade of life. And this is the upper GI counterpart. It is the counterpart of angiodysplasias. It is the counterpart of angiodysplasias seen in colon. So you remember angiodysplasias on the right side of colon can be seen in elderly patients. Those are also arterioles. Similarly, these Dieulafoy's lesions are also arterioles which are present in the stomach, and they can give rise to upper GI endoscopy. And when endoscopy is done, you can see that these are these subtle lesions, flattish lesions where you can see a dilated vessel, and they can give rise to bleeding. The management is endoscopic cauterization, or we can do embolization of these vessels. Or embolization of these vessels can be done. So these are Dieulafoy's lesions. And one more point which I want you to remember, that unlike GAVE where females were more commonly affected, Dieulafoy's lesions, males are more commonly affected than females. The next condition which we need to talk about is Menetrier's disease. Now, Menetrier's disease is also a rare condition, and in this what happens, there is hypertrophy of the gastric mucosal folds. So you can see in the image there is hypertrophy of the gastric mucosal folds. So you will have giant gastric mucosal folds in these patients, and this is mediated by TGF alpha, right? TGF alpha is the one which mediates this hypertrophy of the gastric mucosal folds. And because of the hypertrophy of these gastric mucosal folds, let's look at the clinical features. So the earliest clinical feature is protein losing enteropathy. These patients are going to lose protein, right? Because of the increased surface area of these mucosal folds, there's going to be protein loss in these patients. That is the earliest clinical feature or the earliest manifestation. This was asked in the All India exam 3 or 4 years back. In addition to this, these patients have upper GI hemorrhage. They will have upper GI hemorrhage, and there is an increased risk of gastric cancer. In these patients as well. So these are the manifestations with Menetrio's disease. The diagnosis will be by an upper GI endoscopy. Upper GI endoscopy will clinch the diagnosis, and the management of these patients. So the management of these patients, first we try medical management. Medical management in the form of cetuximab is tried. So cetuximab, you know, is a monoclonal antibody which can be used for the medical management. If it does not work, then the treatment is gastrectomy. Then we need to carry out a gastrectomy in these patients. So that is the management of patients with Menetrio's disease. The final non-variceal cause of upper GI hemorrhage which I want to discuss are tumors. And tumors, you know, like gastric cancer, it can be a cancer, or it can be GIST, gastrointestinal stromal tumors. In the stomach module, I've told you about gastrointestinal stromal tumors, and I've told you that the most common manifestation of gastrointestinal stromal tumors is upper GI hemorrhage. And I fondly remember this case because this was the case where I got to fire a GI stapler for the first time. I was in my second year, and there was this lady who had come with massive upper GI hemorrhage. And she came once, the bleeding stopped, and she was managed conservatively, and scopy was not done. So somehow the scopy was not done, and then when she came the second time, within a span of 1 day, she was bleeding profusely. She came in hypovolemic shock. Blood transfusion was done, a scopy was done, a CT was done, and it was found out that she had a gastric GIST. And this was the first time I did a wedge resection and I had fired a GI stapler. So I clearly remember that case. So tumors can also give rise to upper GI hemorrhage, and you need to remember this. Another point which I want to reiterate, I've covered this in GIST. GISTs can also be missed during endoscopy, and the investigation of choice for gastrointestinal stromal tumors is CECT. So this was the summary of non-variceal causes of upper GI hemorrhage. Let's now shift our attention to variceal upper GI hemorrhage. Now, you know, variceal upper GI hemorrhage, esophageal varices, are seen in patients with portal hypertension, right? And to measure portal hypertension, we have to measure the hepatic venous pressure gradient, or HVPG. And this HVPG, how do we measure this? We directly cannulate one of the hepatic veins. And we first are going to measure the wedged hepatic pressure. We first measure the wedged hepatic venous pressure. This is measured when the balloon is inflated, right? So this is measured when the balloon is inflated, and we subtract the free hepatic venous pressure. This is measured when the balloon is deflated. Right? So HVPG is what is calculated, and that is when we measure the gradient and we call it portal hypertension. If the pressure is 10 or more than 10 millimeters of mercury, we call it portal hypertension. We call it portal hypertension, and at this pressure it manifests clinically. So clinical features would start, and at a pressure of 12 or more millimeters of mercury, the varices start to bleed. The varices start to bleed. So you need to remember these two pressure values, and you need to know HVPJ. So 1 to 5 is normal, 6 to 10 is when preclinical, it is known as preclinical portal hypertension. The symptoms or the features are not going to be there. The features start at 10 or more than 10, this I have told you. At 12 or more than 12, the varices start to bleed. So these are pressures which you need to remember for the exam. Now talking about the causes of portal hypertension. What are the various causes of portal hypertension? So the causes can be divided into extrahepatic causes, or they can be divided into intrahepatic causes, right? So extrahepatic causes of portal hypertension can be portal venous thrombosis, portal vein thrombosis. This is extrahepatic portal vein thrombosis, right? This is extrahepatic portal vein thrombosis, which I will just cover in detail in 2 minutes. The other causes, you can have left-sided portal hypertension. This is left-sided portal hypertension. This is also known as sinistral portal hypertension. This is also known as sinistral portal hypertension. And the cause of this left-sided portal hypertension or sinistral portal hypertension, I've covered this in the pancreatitis module, is splenic vein thrombosis. I've covered it in the pancreatitis module because the most common cause of splenic vein thrombosis is acute pancreatitis. It is secondary to acute pancreatitis. And in these patients, the management is splenectomy. Other causes can be trauma and tumors. So just a few words regarding this portal vein thrombosis or extrahepatic portal vein thrombosis. Now this extrahepatic portal vein thrombosis is usually seen in patients in the first or the second decade of life. And in this, there is a cavernous change in portal vein, which gives rise to a web within the portal vein, and that is what gives rise to fibrosis and blockade of the portal vein. Now, this extrahepatic portal venous obstruction can either have a fulminant course, and if it has a fulminant course, the patient is going to come with liver failure. But if it is a gradual course, then portal hypertension and splenomegaly can be there. Now, the reason why I'm telling you this is because this needs to be differentiated from one of the intrahepatic causes. Now, intrahepatic causes can be further subdivided into pre-sinusoidal, sinusoidal causes. You know that there are sinusoids inside the liver, and either the causes can be before the sinusoids, within the sinusoids, or post-sinusoidal, after the sinusoids. Now, the pre-sinusoidal causes can either be Ascariasis, Ascaris worms can be there, clonorchis infection or Chinese liver fluke infestation, or one of the causes is non-cirrhotic hepatic fibrosis. And this is what we need to differentiate extrahepatic portal venous obstruction from? Now, non-cirrhotic portal venous fibrosis, as the name suggests, there is no cirrhosis. And you know, one of the hallmarks of cirrhosis is bridging fibrosis. So there is no bridging fibrosis. There is no bridging fibrosis which is seen in these patients. And this is seen in 3rd to 4th decade of life. It is seen in 3rd to 4th decade of life. And this one is a diagnosis of exclusion. It is a diagnosis of exclusion. And like the portal venous obstruction which I just told you, it can either have a fulminant course. The clinical features, it can either have a fulminant course. And if it has a fulminant course, the patient is going to come with liver failure. The patient is going to come with liver failure. Or if it has a gradual course, then there will be portal hypertension. The management, irrespective of the two, is a transplant. Ultimately, the patient requires a liver transplant to take care of this condition. So this was the pre-sinusoidal cause which you should know about. Now, sinusoidal causes of portal hypertension are the various causes of cirrhosis. You know, cirrhosis can either be due to alcohol. It can be alcoholic cirrhosis. It can be viral cirrhosis. Hepatitis B, C virus, you know, can give rise to viral cirrhosis. It can be cryptogenic. It can be cryptogenic cirrhosis, or alpha-1 antitrypsin deficiency can give rise to this. Or this can even be seen in Wilson's disease. So these are the various causes of sinusoidal portal hypertension. Most of these have been covered in pathology and medicine in great detail, so I am not going to discuss these in detail. The post-sinusoidal causes can be severe tricuspid regurgitation. It can be severe tricuspid regurgitation. And you know, if there is tricuspid regurgitation, you will get a pulsatile enlargement, right? You can see a pulsatile enlargement of the liver. So severe tricuspid regurgitation can be one of the cause. Budd-Chiari syndrome, this we need to discuss in detail. Budd-Chiari syndrome is very important, or constrictive pericarditis. Now, Budd-Chiari syndrome we need to discuss. Budd-Chiari syndrome is hepatic venous outflow obstruction. So what happens is that a web forms in the venous outflow system, giving rise to blockade there. And what are the predisposing factors for Budd-Chiari syndrome? The predisposing factors for Budd-Chiari syndrome are all the hypercoagulable states. The hypercoagulable states, it can be seen in pregnancy. It can be seen when there is protein C and S deficiency. It can sometimes be seen in malignancy as well. Malignancy is also a prothrombotic state. Commonly, this is seen in young females. So the clinical features, it is commonly seen in young females. They are the ones who are commonly affected. Again, you can have a fulminant course. A fulminant course can be there, where this is rapidly progressive and it would come with liver failure. The patient is going to come with liver failure. Or it can have a more gradual course, like in majority of the cases, where there can be portal hypertension, abdominal pain can be there. Right now, this diagnosis is made by imaging. So imaging will clinch the diagnosis. CT, you will see the web-like appearance in the outflow tract. That is what clinches the diagnosis in these patients. And one more thing, if you remember, when I was telling you about the anatomy of liver, I told you this is one condition where segment 1 of liver undergoes, or the caudate lobe, you know, segment 1 is caudate lobe, undergoes hypertrophy. And why does the segment 1 or caudate lobe undergo hypertrophy? Because if you remember the liver anatomy, I told you that this segment 1 has independent venous drainage directly into the IVC, right? This has independent venous drainage directly into the IVC, which is why this hypertrophies, because rest of the outflow is obstructed. So this one hypertrophies and there is direct venous drainage into the IVC. The management of these patients, so lifelong anticoagulation has to be given. Lifelong anticoagulation has to be given in these patients. If it has a fulminant course and there is liver failure, if it is a fulminant course, then a transplant needs to be done in these patients, and always try to identify the cause and treat that as well. So these are the various causes of portal hypertension. Now, what are the clinical manifestations of portal hypertension which one should be aware of? So we've discussed the causes. Now we are talking about the clinical manifestation of portal hypertension. So the clinical manifestation of portal hypertension, patients are going to present with ascites. Patients are going to come with splenomegaly. They can have splenomegaly, they can have ascites, they can have features of liver failure. There can be features of liver failure. And very importantly, whenever there is portal hypertension, there are portosystemic shunts which are formed. So portosystemic shunts are formed, and what are the various areas? So this is a common viva question which is asked, what are the various areas where these portosystemic shunts are seen? So these portosystemic shunts can be seen in the region of the esophagus, and this is where the varices form, the esophageal varices, which we'll discuss in detail. They can be seen in the rectum, and you can get these rectal varices, right? So rectal varices can form. Mind you, please don't confuse these rectal varices with hemorrhoids. Hemorrhoids are different and these varices are different, and the causes of both of them are quite different. So they should not be confused. So portosystemic shunts can give rise to rectal varices as well. The other areas are the bare area of the liver, the bare area of liver. You know which segment this is. This is segment 7 of the liver, which is the bare area. I've covered this in the surgical anatomy. This can be seen in the retroperitoneum, and one area where you can get a very typical sign is the umbilicus, and you all know the sign which is seen in the umbilicus. You get the caput medusae sign. You get these vessels radiating out of the, umbilicus. The vessels above go in the upward direction, below they go in the downward direction. So this is the caput medusae appearance, which you should know about. This is also a site of portosystemic shunts. So these are the clinical features which you get in patients of portal hypertension. The investigation of choice is a Doppler. Color Doppler is the investigation of choice for portal hypertension. And what do we want to measure? The investigation of choice is a Doppler. And what do we want to measure in these patients? We want to measure the hepatic venous portal gradient, which I've already explained to you. A hepatic venous portal gradient of more than 10 is when clinically significant portal hypertension is going to start. So we have discussed about portal hypertension, the causes. I've told you how to diagnose the condition, and now we need to discuss the algorithm to manage variceal upper GI hemorrhage. This algorithm is very important. Every year, every exam, there is at least one question from it. So everyone should know about this. So we are going to talk about the algorithm to manage upper GI hemorrhage due to variceal causes. Before that, I want you to know the Baveno classification. This is a classification, endoscopic classification for esophageal varices. You can have, so remember the name please, you can have small varices. These are minimally elevated above the mucosal surface. Medium are tortuous varices occupying less than 1/3 of the esophageal surface. So less than 1/3 of the surface if they are involving, these are medium varices, and if they involve more than 1/3 of the area, then they are known as large varices. They occupy more than 1/3 of the esophageal surface. So this is just an endoscopic classification, right? Now the algorithm to manage bleeding varices, these patients are going to come with upper GI hemorrhage. Usually these patients are going to be hypotensive, and because they have portal hypertension or due to cirrhosis, they can even have encephalopathy like features. So when they come to you, they might have altered sensorium also. So the first thing which needs to be done whenever you get a patient with upper GI hemorrhage into the emergency is ABC. We already know what ABC is. A is for airway. Why is the airway important in these patients? Because when they are vomiting out blood, or when they are bleeding, they can aspirate that, and that can be catastrophic. So airway control is also very important. B is to look for breathing. And C is for circulation. So in circulation, the first thing which we need to do is insert 2 large bore IV lines. And we need to give fluids to these patients. IV fluids need to be given to these patients. One thing which I want you to remember, that there should not be an indiscriminate use of IV fluids, right? Don't just give IV fluids, don't just let them rush. So you need to understand that if there is a tear, why is there bleeding occurring? Because there is a tear in the vessel, right? Now, if I give too much of fluids, right, the BP is going to shoot up. And if the BP shoots up, the tear is going to increase. So actually it's going to cause more bleeding, right? So fluids need to be given, but if you remember, I told you about the concept of permissive hypotension. That means maintain the BP around the lower limit of normal so that due to excessive fluid use, bleeding does not increase. Now, once we've done this, there are certain IV agents which are given, and this is very important for your exam. The best IV agent in variceal bleed, is IV terlipressin. This has been asked in the exam. The best IV agent used is IV terlipressin, but the availability of IV terlipressin is an issue. So the most common IV agent which is used in upper GI hemorrhage is IV octreotide. Right? One thing which you need to remember, that the earlier books used to say that pantoprazole should be the first agent which should be given, right? But now the latest Bailey writes that IV PPIs, proton pump inhibitors, have no role before endoscopy. Upper GI endoscopy. They should be given after upper GI endoscopy. After assessing what is the cause, they can be given, but no role before upper GI endoscopy. And one final question which has been asked in the exam: which IV agent is not used? Which IV agent is not used in an acute setting when there is upper GI hemorrhage? And the answer here is IV propranolol. Now you know propranolol is a beta blocker. And if I give IV propranolol when the patient is bleeding, already hypertensive, the patient will become more hypertensive. The patient can die. So no IV propranolol. We do give oral propranolol in varices, but that is used as prophylaxis. I will tell you where oral propranolol is used, but no IV propranolol. It can cause sudden hypotension, right? So we manage the patient, we stabilize the patient, we give these IV agents, and once we've done that, then the patient is taken up for an upper GI endoscopy. Now, when we do this upper GI endoscopy in a patient with esophageal varices, there are 2 ways to stop the bleeding. Stop variceal bleeding. There are 2 ways on upper GI endoscopy. We can either do a band ligation. We can either do a band ligation or we can do sclerotherapy. These are the same two treatments which I told you for hemorrhoids as well, and there also I told you that band ligation is superior to sclerotherapy. So band ligation is a better modality than sclerotherapy, and this is how we do a band ligation. You can see that you have a bleeding varices and you just tie a band around the base of the varices to stop the bleeding, right? You just tie a band around the base of the varices to stop the bleeding. On the other hand, sclerotherapy. So sclerotherapy, we inject a sclerosing agent. This also we've discussed at various places in hemorrhoids also and in varicose veins, that the most commonly used sclerosing agent is sodium tetradecyl sulfate. That is the most commonly used. The other agents which can be used are sodium moruvate, polydocanol, and ethanol amine oleate. So these are the various sclerosing agents which are used in sclerotherapy for varices. The complications of sclerotherapy, what are the various complications? Patients can start complaining of chest pain after the procedure. But mind you, chest pain after endoscopy can, for this purpose, can either be due to the sclerotherapy agent being injected, but sometimes chest pain after endoscopy can also signify an iatrogenic perforation. So you need to be careful in assessing the two. So there can be chest pain, sometimes there can be a perforation as well, right? So these are the complications of sclerotherapy. So once we've done an initial upper GI endoscopy and we've done either banding or sclerotherapy, there can be two outcomes, right? So after the upper GI endoscopy, there can be two outcomes. And the outcome can either be that the bleeding stops. If the bleeding stops, it's good for everyone. Now if the bleeding stops, then what do? Then we monitor the patient for 24 hours, because 24 hours is the period when rebleeding can occur, right? So to assess for rebleeding, we monitor the patient for 24 hours. If the patient does not bleed, if no bleeding is there, then we discharge the patient. But when we discharge the patient, we discharge the patient on oral propranolol. Now oral propranolol, like I told you, propranolol is a beta blocker, and this is basically used as prophylaxis. It brings down the portal pressure and it prevents bleeding. So it is used as prophylaxis, but oral propranolol is used. There is no role of IV propranolol in variceal upper GI hemorrhage. Now if the bleeding continues, or if the patient rebleeds, there can be two options. There can either the patient's bleeding continues once you finish the endoscopy, or the patient rebleeds. Now in this case, we give a second trial of upper GI endoscopy. A second trial of upper GI endoscopy is done in these patients. This you should know. This has also been asked in the exam. You straight away don't do any surgical intervention or shunts. We give a second trial of endoscopy. Now, once we do the second trial of endoscopy, if patient rebleeds after this, if patient rebleeds after a second trial of endoscopy, now we prepare the patient for TIPS. I'll tell you what TIPS is. TIPS is type of a shunt, but we have to prepare the patient for TIPS, right? And preparation for TIPS would be that these patients with portal hypertension or cirrhosis can have an altered coagulation profile. So for preparation, we have to correct the coagulation profile for a procedure. We have to correct the coagulation profile of these patients. And till then, we have to temporarily stop the bleeding. Temporarily stop bleeding. And to temporarily stop the bleeding, what are the various interventions which we can do? There are some tubes which can be used to temporarily stop the bleeding. And the most commonly used tube is a Sengstaken Blakemore tube, right? So this one here is a Sengstaken Blakemore tube. Now to stop the bleeding, you can see here that these are the 3 tubes, and this one I told you is the Sengstaken-Blakemore tube. This is the Minnesota tube, and this one is the Linton's tube. And very important question, how do we differentiate between these 3 tubes? Because it was asked in the INI CET exam as well, and it was asked previously also. Now the Sengstaken-Blakemore tube, I'll go back to the previous diagram. Sengstaken-Blakemore tube has 2 balloons, right? It has 2 balloons. It has a gastric balloon. There is a gastric balloon, and there is an esophageal balloon. And it has 3 channels, right? It has a gastric aspiration channel. And these 2 channels are for the 2 balloons, to inflate the 2 balloons, the gastric and the esophageal balloon. Now what we do is, to temporarily control the bleeding, I put in this tube and first I inflate the gastric balloon, right? So the gastric balloon is inflated first. And how much do we inflate it? We inflate it with 300 ml of air. So we inflate the gastric balloon and we hitch up the tube, right? So I inflate the gastric balloon and I hitch it up. So when I hitch it up, it puts pressure on the gastroesophageal junction, and it can stop the variceal bleeding due to a tamponading effect, right? If bleeding continues, then esophageal balloon is inflated. And how much do we inflate the esophageal balloon? We inflate it to 40 millimeters of mercury. But the important thing is, it should be deflated. Every 12 hours, at least every 12 hours. And why do I need to do that? To prevent esophageal necrosis. So this is one of the problems, that necrosis can occur. Also, if you overinflate the balloons, a perforation might also occur. So you need to remember the pressures, and you need to remember that Sengstaken-Blakemore tube is temporarily stopping the bleeding. Now a drawback of the Sengstaken-Blakemore tube is that you can see here that it only has 3 channels. There is a gastric aspiration channel and the 2 channels for balloons. But if there is any collection in the esophagus, there is no esophageal aspiration channel. And that is the thing which is overcome by the Minnesota tube. Now Minnesota tube, again there are 2 balloons, esophageal and gastric, but Minnesota tube has 4 channels. So it has a gastric and esophageal. It has a gastric and esophageal aspiration channel as well. And the other 2 channels are for the balloons. So that is the advantage of a Minnesota tube over a Sengstaken-Blakemore tube. Linton's tube, you can see here, Linton's tube has only a single balloon. So that is how you can identify it. It has a single balloon, which is the gastric balloon, and it has 3 channels. So one channel is for the balloon, and one is the esophageal, and one is the gastric aspiration channel. So these are the 3 tubes which can temporarily stop the bleeding. You should be able to identify them. It's a very, very important topic for the exam. Now, why are we putting in this tube and correcting the coagulation profile? Because we want to carry out TIPS. Now, what is TIPS? TIPS is transjugular intrahepatic portosystemic shunt. Now, a very long name, but what is the actual principle behind it? It's quite simple. What we are doing in TIPS is we are going through the internal jugular vein, and we go into a hepatic vein and we are creating a stent. We are putting in a stent between a hepatic vein, and portal vein. So between hepatic vein and portal vein, we are putting in a stent. So what is going to happen is that preferentially blood is going to flow through the stent. Preferential blood flow through the stent, and this is going to give rise to a reduced portal pressure. This is going to give rise to a reduced portal pressure, and the bleeding is going to stop. Now, TIPS does not come without complications, and there are two questions which have been asked in the exam. The complications, what is the most common early complication of TIPS? What is the most common early complication of TIPS? And what is the most common late complication of TIPS? So the most common early complication of TIPS is encephalopathy. It precipitates encephalopathy. And why does it do that? I will just explain it to you in 2 minutes. But this is the most common early complication of TIPS. And the most common late complication of TIPS is that the stent can get blocked. Stent blockade can be there, and again increase in portal pressure. There can be again increase in portal pressure, and there can be bleeding. Right? So you need to understand these two complications. In addition to this, there can always be hemorrhage as well while we are inserting the stent. What are the indications for doing TIP? The indications for doing TIPS are patients with variceal bleeding which is not getting controlled, and also in Bailey it is clearly written that for intractable ascites related to portal hypertension, in that also we can carry out TIPS. Now TIPS, I told you, is a shunt, right? It's basically a shunt. It is a type of a non-selective shunt. Now, what is the meaning of a selective versus a non-selective shunt? Let's understand the concept behind these shunts. So, shunts for portal hypertension can either be non-selective shunts or you can have selective shunts. Now let's understand this. So you know how is the portal vein formed? Portal vein is formed when the splenic vein is going to join the superior mesenteric vein. That is when the portal vein is formed, right? So splenic vein and superior mesenteric vein. You know, splenic vein is bringing blood from the spleen. The superior mesenteric vein is bringing blood from the bowel, right? The blood coming from the bowel has toxins in it, and when the portal vein forms, these toxins go into the liver and they get metabolized, right? They don't leak out into the systemic circulation. But if these toxins find a way into the systemic circulation, they can precipitate encephalopathy, right? So that is the basis of selective versus non-selective shunt. Selective shunt is only splenic blood is shunted. Now, if you are shunting only splenic blood, no encephalopathy. The example here is distal splenorenal shunt. Also known as Warren's shunt, right? Another one is Inokuchi shunt. Inokuchi shunt is also an example of a selective shunt. This is left gastric venocaval shunt, right? So these are selective shunts. Non-selective shunts, bowel plus splenic blood. Both are shunted. Now, if you know that if bowel blood is shunted, this is carrying toxins. And if you shunt this blood, you are giving it free access into the systemic circulation, and this is going to cause encephalopathy. That is why all non-selective shunts, mind you, all non-selective shunts can precipitate hepatic encephalopathy because the toxins find a free passage into the systemic circulation. So let's look at these shunts now, right? Let's look at the shunts. I already told you distal splenorenal. This one is a distal splenorenal shunt. This is known as a Warren's shunt, and it is a selective shunt, right? You can also have a proximal splenorenal shunt. Proximal splenorenal shunt plus splenectomy. This is known as a Linton's shunt. But mind you, Linton shunt is non-selective. Why is Linton shunt non-selective? Because there can be backflow of bowel blood from the superior mesenteric vessel into the splenic vessel, right? Into the shunt. So from the superior mesenteric vein into the shunt, there can be backflow. That is why the proximal splenorenal shunt is a non-selective shunt. You can also have a portocaval shunt. A portocaval shunt. This is an end-to-side portocaval shunt. This is known as an X fistula. ECK, X fistula. And this is also a non-selective shunt because we are doing the shunt with the portal vein when the bowel blood has already gone into it. And you also have a side-to-side splenorenal shunt. A side-to-side splenorenal shunt is there. This is known as a Mitra's shunt. This is also a non-selective shunt. So these are the various shunt procedures. You should definitely know about Inokuchi, Warren's, Linton's, and X fistula. Now, what are the indications for carrying out shunt surgery? The indication mainly for shunt surgery is a patient with child PUG A. I'll tell you about child PUG classification. These scores for liver failure are very, very important. Again, it was a hot favorite of PGI and JIPMER, and now it will find its way into the INI CET exam as well. Twice it has been asked in the NEET exam also in the last 5 years. So the child PUG score is important. So child PUG A with variceal bleeding, which is not getting controlled by endoscopy, that is where we are going to carry out these shunts, right? If shunt surgeries also cannot control bleeding, then a very radical procedure is known as Seguira's procedure. So if shunt surgeries cannot control bleeding, we will do Seguira's procedure. This is known as esophageal devascularization procedure. This is esophageal devascularization procedure where the lower 6 centimeters of esophagus is devascularized so that this bleeding can be controlled. But this is at the absolute last resort in these patients. So I've told you the flow of sequence of how do we manage this patient with variceal bleeding. It is very, very important from the point of view of the exam. Now, any patient who is coming with upper GI hemorrhage, there are certain scores which you need to know. I already mentioned the child PUG score. This is one of the scores which measures liver failure. So the child PUG score, the criteria are 5 criteria are there: encephalopathy, ascites, bilirubin, albumin, and prothrombin time. You need to remember these 5 criteria. You need to remember the details as well, right? So it is given us, every parameter is given a score of 1 to 3. No encephalopathy is 1, mild encephalopathy is 2, severe encephalopathy is 3. Ascites, no ascites is 1, moderate ascites is 2, and severe is 3. How do we know it is mild to moderate and how do we know it is severe? If it is diuretic responsive, it is mild to moderate. If it is diuretic refractory, it is severe. Bilirubin less than 2 is 1. Bilirubin 2 to 3 is 2. More than 3 is 3. Albumin more than 3.5 is 1. 2.8 to 3.5 is 2. And less than 2.8 is 3. Prothrombin INR less than 1.7 is 1. 1.7 to 2.3 is 2. And more than 2.3 is a score of 3. Higher the score, poor the liver function. Child Pug A, you can see here, Child Pug A is a score of 5 to 6. Child Pug B is a score of 7 to 9. And Child Pug C is a score of 10 to 15. So you need to remember all the parameters of the Child Pug score. Similarly, for children, you have the PELD score, the pediatric end liver disease score. This I have covered in the transplant module, also in the liver module. The pediatric end liver disease score is there for children, and the MELD score, the model for end stage liver disease score, is also there. This also I have covered in the liver module and the transplant module. These two scores also you should know about. Another score for upper GI hemorrhage, this is a prognostic score. This is the bleed criteria. This is a prognostic score. This is the bleed criteria. B is for ongoing bleeding, L is for low systolic BP, E is for elevated prothrombin time, E is for erratic mental status, and D is for comorbid conditions. So it just basically is a prognostic score. Another very important score asked previously in the exam is the Forest criteria. The Forest criteria is an endoscopic criteria. It is an endoscopic criteria which tells us about the risk of rebleeding. It tells us about the risk of rebleeding. This has been asked many times in the exam. So those who are preparing for the INI CET exam, you should know the details. 1A is spurting hemorrhage. 1B is oozing hemorrhage. Both of them have a high risk of rebleeding. High risk of rebleeding. Right? 2A is a non-bleeding visible vessel. 2B is an adherent clot. They have a medium risk. They have a medium risk of rebleeding. And you have 2C is flat pigmented spot, and 3 is a clean ulcer base. When you can't see active bleeding, right? These have a low risk of rebleeding. So this is the Forest criteria. For INI CET, you should know the details of the Forest criteria. Another score is the Rockall score. Remember the name, please. Rockall score is also a prognostic score in patients with upper GI hemorrhage. And the one which was asked in the UPSC exam 2 years back is the Glasgow-Blatchford scoring system. The Glasgow-Blatchford scoring system, intervention is required if the score is 6 or more. You should remember this, please. Intervention, if the score is 6 or more, intervention is required in these patients, right? So these are the various scoring systems. The algorithm I've highlighted for you. For final year students in this module, what is important for final year students before I discuss the MCQs? So this can be a long question. You can be asked the entire algorithm. You can be asked about tips. You can be asked about Child Pug score. You can be asked about Mallory-Weiss tear. Mallory-Weiss tear has been asked many times in the exam as well. Gastritis also sometimes can be a short note, right? So you should know all these from the point of view of the final year. This was the question which was asked in the AIIMS exam. Which of the following is used to stop esophageal variceal bleed? Now we know that these two tubes are used. Now what happened that the images which they had given were so small that you could not differentiate between an upper GI scope and a colonoscope. That is what students said, right? So the safest answer to mark here was all four. But I have shown you the high resolution images, and the main differentiator between a colonoscope and an upper GI scope is the length. So please remember that. Which of the following IV agents is not used in the management of upper GI hemorrhage? Propanolol is not used. Oral propanolol is used as prophylaxis. No role of IV propanolol. Let's just match the following. The shunts, Warren shunt, you know, is a distal splenorenal shunt. It is a selective shunt. Linton's shunt is a proximal splenorenal shunt. non-selective shunt. Inokuchi shunt. Inokuchi is left gastric venocaval shunt. Ex fistula is an end-to-side portocaval shunt, again a non-selective shunt. And Seguera's procedure is esophageal devascularization procedure. Regarding upper GI hemorrhage, gastritis is the most common cause of upper GI hemorrhage. False. We've discussed this. Gastritis is the second most common cause. Peptic ulcers are the most common cause. Duodenal ulcers bleed more commonly than gastric ulcers. Duodenal ulcers bleed more commonly than gastric ulcers. This is true. Majority of Mallory Weiss tears can be managed conservatively. True. I told you they're self-limiting. TNF alpha is implicated in the pathogenesis of Menetrier's disease. This is false. I told you it is TGF alpha, not tumor necrosis factor. It is tumor growth factor alpha. Menetrier's increases the risk of gastric cancer. Yes. And splenic vein thrombosis can give rise to left-sided portal hypertension. This is also true. This is post-pancreatitis, and this is also known as sinistral portal hypertension. So that brings us to the end of this very important module on upper GI hemorrhage. If you have any further questions regarding any of the modules or any questions regarding to the course or any doubts, you can always ask me those questions on the Marrowlinks Facebook group, or you can contact me on my social media handles. The best is to send me a message on Instagram on Left-Handed Surgeon. But utilize the Marrowlinks Facebook group. That is a group which has been made for you to ask your queries. You should ask your queries there.